Hi everyone. This week and next week we will be covering the respiratory system. Respiration involves both the respiratory and the circulatory systems and involves four processes that supply the body with oxygen and dispose of carbon dioxide. Respiration consists of contributions, as we mentioned, from both the respiratory system and the circulatory system. As far as the respiratory system goes, pulmonary ventilation, otherwise known as breathing, moves air into and out of the lungs. External respiration moves oxygen and CO2 between the lungs and the blood. Transport takes place within the circulatory system, moving oxygen and carbon dioxide in the blood, and leading to internal respiration, where oxygen and CO2 exchange takes place between systemic blood vessels and body tissues. The major organs of the respiratory system include the nose and nasal cavities, the paranasal sinuses seen in the skull, the pharynx or throat, the larynx or voice box, the trachea, aka the windpipe, the bronchi and their various branches, and then the lungs and the individual air exchange sacs known as the alveoli. In terms of the functional anatomy of the respiratory system, there's a conducting zone more superiorly and a respiratory zone more inferiorly and laterally. In the conducting zone is for transporting air from and to the exterior. While passing through the conducting zone, the inhaled air is filtrated, moisturized, and warmed. No gas exchange takes place in this area with the blood or with the body tissues. Just as the name implies, it's simply for transporting the air in and then cleaning up and moisturizing and warming it. The lower respiratory zone is the region of the lung where the gas exchange actually occurs. The respiratory zone also contains an area known as the transitional zone, moving from the conducting into the respiratory. Let's start with the most superior feature of the respiratory system, the nose. Functions of the nose include providing an airway for respiration, moistening and warming the entering air, filtering and cleaning inspired air, serving as a resonating chamber for speech, and housing olfactory or smell receptors. The nasal cavity is lined with respiratory mucosa, which is comprised of pseudostratified ciliated columnar epithelium. If you remember back to Anatomy and Physiology 1, one particular type of epithelial tissue is pseudostratified columnar. So columnar are taller than they are wide, and most of them have cilia, or those little hair-like projections off the apical or top surface. And pseudostratified means that while it looks like more than one layer of cells, due to the varying heights of the nuclei, it's actually only one layer thick. The respiratory mucosa also contains both mucus, with thicker, and serous, thinner secretions, which contain lysozyme and defensins, two antimicrobial and antifungal substances. Cilia also move any contaminated mucus that has trapped microbial life posteriorly to the throat, where it'll be swallowed or coughed up. Inspired air is warmed by plexuses of capillaries and veins within the respiratory mucosa. And the respiratory mucosa also contains sensory nerve endings, which trigger sneezing if any particulate matter enters in to get it out. The nasal cavity also contains the superior, middle, and inferior nasal conchae. These, which kind of look like the shelves of a conch shell, hence the name, protrude from the lateral walls of the nasal cavity and serve to both increase mucosal area, both for warming and for cleaning the air, as well as enhancing turbulence to allow it to stay there longer with more contact to the mucosal area to allow for more filtering time and more warming time. During inhalation, the nasal conchae, those little shelves, and the nasal mucosa filter, heat, and moisten air. During exhalation, these structures reclaim heat and moisture. In addition to the nasal mucosa, we have the paranasal sinuses, a set of 4 in the frontal, sphenoid, ethmoid, and maxillary bones. The paranasal sinuses serve to lighten the skull and to help warm and moisten inhaled air. The pharynx, what we consider the throat, is a muscular tube that connects to the nasal cavity and mouth superiorly and the larynx and esophagus inferiorly. It extends from the base of the skull to the level of the 6th cervical vertebra. The nasopharynx is an air passageway posterior to the nasal cavity. Its lining consists of pseudostratified columnar epithelia, the same as in the nasal mucosa, and it's comprised of the soft palate and the uvula as well, which close the nasopharynx during swallowing. Pharyngeal tonsils, commonly known as adenoids, are found on the posterior wall. You can see them in the lower picture. And then the pharyngeotympanic or auditory tubes open into the lateral walls of the nasopharynx. And so that's why when one's sort of upper skull is draining, you could then get it in the back of the throat. The oropharynx is a passageway for food and air from the level of the soft palate to the epiglottis. It is lined, instead of the pseudostratified, by stratified squamous epithelia, so tougher. Think of what's on like the outside skin. And think for a minute why this is the case, right? In the nasopharynx, you're dealing with mostly inhaled air. Any particulate matter will most likely get caught by the nasal mucosa and either be sneezed or coughed up and out, or swallowed and then meet the stomach acid. Whereas the oropharynx, right, that's taking in what you're eating as well. So think about, I always joke, if you swallow a Dorito that hasn't been sufficiently chewed, right, it's going to go down and rip at that lining, so it has to be more than one layer. The oropharynx extends from an area called the isthmus of the fauces, which is the opening to the oral cavity, and then goes down to the palatine tonsils in the lateral walls of the fauces and the lingual tonsil on the posterior aspect of the tongue. The lower part, or the most inferior part of the pharynx, is the laryngopharynx, and this is a passageway for both food and air. It's posterior to the upright epiglottis, and it extends to the larynx, where it's also continuous with the esophagus. So we've gone from, in the purple, the nasopharynx, in sort of that teal green, the oropharynx, and then in this orangey color, the laryngopharynx. Okay, and here's a more detailed sagittal anatomy. So things we talked about, right? The uppermost, superiormost part of the pharynx, the nasopharynx. You have that pharyngeal tonsil, aka the adenoids back here. You see the opening of the pharyngeotympanic. Remember, tympanic is in the ear. So again, you have the drainage here. And then the uvula, the little hangy ball. And then you go into the oropharynx at the back of the mouth, in the back of the throat here. But when we talk about this is all the throat, right? The oropharynx is behind the mouth. And then you have the laryngopharynx behind the larynx, or voice box. The larynx attaches to the hyoid bone anteriorly and opens into that laryngopharynx. It is continuous with the trachea, aka the windpipe, and functions 1, to provide a patent or open airway, 2, routes for both air and food to move into their proper channels, and 3, as a source of voice production. The cartilages of the larynx include hyaline cartilage, except for the epiglottis. The thyroid cartilage with the laryngeal prominence, or aka an Adam's apple, is seen more readily, right? This little ridge right here in males versus females, but it's there in both. And then you have the ring-shaped cricoid or cricoid cartilage, where you see a little bit of it anteriorly, but posteriorly it expands quite a bit. You can see it in this sagittal view. And then we have paired arytenoid, which I always think you see them better posterior, look like little bat wings, cuneiform, and corniculate cartilages. Then there's an epiglottis, which instead of being hyaline cartilage is actually elastic cartilage and serves to cover the laryngeal inlet during swallowing. So basically the epiglottis will block food or drink from going into the trachea, right? We don't need something solid going into our windpipe. There are two sets of vocal ligaments which attach to the arytenoid cartilages and posteriorly and then anteriorly to the thyroid cartilage. The vocal ligaments contain elastic fibers and form the core of what are the vocal folds. These are the true vocal cords. The opening between these vocal cords or vocal folds is called the glottis, right? The epiglottis is above it, and these folds vibrate to produce sound as air rushes up from the lungs. Then there are the vestibular folds, aka the false vocal cords, which are found superior or above the true vocal folds and play no part in sound production but actually help to close off this area during swallowing, again to reinforce the role of the epiglottis and not let food or liquid into our windpipe. In terms of voice production, when we think of speech is the intermittent, right, sort of in little bursts, the intermittent release of expired air while opening and closing the glottis, the opening between the vocal folds. The pitch of one's voice is determined by the length and the tension produced of the vocal cords. The volume or loudness depends upon the force of the air through these folds. And the chambers of the pharynx, the oral, the nasal, and the sinus cavities work together to amplify and enhance sound quality of one's voice. The sound is shaped into language by the muscles of the pharynx, the tongue, the soft palate, and the lips. The vocal folds may act as a sphincter of sorts to prevent air passage. An example is during something called Valsalva's maneuver. This type of maneuver would be used if you're lifting something heavy or you're trying to empty the rectum. The glottis closes to prevent any air from being exhaled, and the abdominal muscles contract. So you're not letting any air escape, and you're actually constricting the abdominal cavity to put more pressure on the air that's in there. When this happens, intra-abdominal pressure rises. So if one is trying to empty their bowels, right, it's going to push everything out. Or if you're trying to stabilize to lift something, you're trying to give support to your back and to your abdominal muscles, so you close off anything exiting or entering. Next comes the trachea, which is more commonly known as the windpipe, which extends from the larynx into the mediastinum, that area between the heart and the lungs, or that contains the heart and the lungs, rather. The wall of the trachea is composed of 3 layers. The innermost layer is known as the mucosa, and this is coated or lined with ciliated, pseudostratified epithelium with goblet cells, those cells that look like little light bulbs and squeeze out mucus onto the apical side that contains the cilia. Next comes the submucosa, which is a connective tissue layer studded with seromucous glands. And then the adventitia, which is the outermost layer made up of connective tissue that encases those characteristic C-shaped rings of hyaline cartilage seen on the exterior of the trachea. The trachealis muscle connects the posterior parts of those cartilaginous rings of the trachea and contracts during coughing to expel mucus. So you have the trachea anteriorly here and the trachealis muscle posteriorly behind it. The carina is the last tracheal cartilage and the point at which the trachea branches into the 2 main bronchi, the left and the right main bronchi. Okay, so this is just a bigger view. Air passages undergo 23 orders of branching at this level. This branching pattern is called the bronchial or respiratory tree. The trachea divides into the right and left main or primary bronchi. Each main or primary bronchus enters the hilum of one lung. The right main bronchus is wider, shorter, and more vertical than the left. And this actually contributes sometimes to things getting lodged more preferentially in the left because it's not as vertical and things can get clogged in there. Each main bronchus branches into lobar or secondary bronchi. There are 3 secondary or lobi bronchi on the right because there are 3 lobes to the right lung, and 2 lobar or secondary bronchi on the left because there are 2 lobes to the left lung. So each lobar bronchus supplies 1 lobe. Each lobar bronchus then branches into segmental or tertiary bronchi. These segmental bronchi then divide repeatedly. Bronchioles are less than 1 millimeter in diameter. So how do you differentiate between a bronchus and a bronchiole? The diameter. The terminal bronchioles are the smallest, coming in at less than 0.5 millimeters in diameter. When we talk about the conducting zone, right, that is just bringing air in from the outside, warming it, cleaning it, we're looking from the bronchi through the bronchioles, and through this transition, we see structural changes occur. The cartilage rings give way to cartilage plates, and then when we get to the bronchioles, the cartilage is completely absent. The epithelium changes from pseudostratified columnar to cuboidal, and the cilia and the mucus-producing goblet cells become sparse. The relative amount of smooth muscle, on the other hand, increases as we move from the bronchi into the bronchioles. The respiratory bronchioles, alveolar ducts, and alveolar sacs, or clusters of alveoli, make up the respiratory zone, where all of the gas exchange occurs. Because there are over 3 million alveoli, this accounts for the greatest surface area in the lungs and the thinnest walls to facilitate gas exchange. So here you can see the terminal bronchioles moving into the respiratory bronchioles, and then each into these alveolar sacs comprised of individual alveoli. And this is a microscopic section. All these what look like empty spaces are the air-filled alveoli. And what you'll notice is that those alveoli are completely surrounded by a vascular network. So what we refer to as the respiratory membrane is about a half a micron, right? A micron is 1/1,000,000th of a meter thick air-blood barrier. Why is this all air-blood? Because we need to take the gas that we're breathing in and put it into the oxygen that we're breathing in and put it into the blood to be delivered to the tissues. And oppositely, we need to take the carbon dioxide waste being produced at the tissues and put it into the lungs to be exhaled out. So the alveolar and capillary walls and their fused basement membranes make up what's known as the respiratory membrane. The alveolar walls are only a single layer of extremely thin squamous epithelium, type 1 cells, and then scattered throughout are type 2 cuboidal cells, which secrete surfactant, which is like almost like dish soap, and prevents the alveolar walls from collapsing in on themselves, similar to how you wouldn't want a balloon to completely deflate because then it just collapses, as well as antimicrobial proteins because we want this area to be sterile, otherwise we have pneumonia. Okay, so here's just an enhanced view, and you can see how greatly vested the capillary network is with the alveolar walls. And here's a scanning electron micrograph of casts of alveoli and pulmonary capillary showing just how interspersed they are at the respiratory membrane. Alveoli are surrounded by fine elastic fibers, and they contain open pores to regulate gas pressure throughout. So these pores connect adjacent or neighboring alveoli and allow air pressure throughout the lungs to become equalized, so we don't have one area blowing out or one collapsing. The alveoli also house alveolar macrophages. Remember, macrophages are immune cells who are professional phagocytosers and eat up microbes and work to keep the alveolar surfaces sterile. Why is that important? Because if they're not kept sterile and an infection ensues, white blood cells will start to migrate to the area, and as you can imagine, pus is not conducive to air exchange, to gas exchange. We want these to be open. The lungs occupy all of the thoracic cavity except for the mediastinum where the heart is. The root of the lungs is the site of vascular and bronchial attachments, and the costal surface on the anterior, lateral, and posterior surfaces are those that face the lungs, hence costal. The apex of the lungs, unlike the heart, is actually the top, the superior tip. The base is the inferior surface that rests right on the diaphragm. The hilum is on the medial or mediastinal surface and is the site for the attachment of blood vessels, the two major bronchi, lymphatic vessels, and nerves. And the cardiac notch is found only on the left lung, and it's a concavity or an indentation that serves to accommodate where the heart is. The left lung is smaller, separated into only 2 lobes by an oblique or diagonal fissure. The right lung has 3 lobes, separated by both an oblique and horizontal fissure. The bronchopulmonary segments are 10 in the right lung, which is larger, and between 8 and 9 in the left. Lobules are the smallest divisions and are served by bronchioles and their various branches. The pulmonary circulation, as we learned in the cardiovascular unit, is a low-pressure, high-volume circuit. The pulmonary arteries deliver systemic venous blood that is seeking oxygenation. They branch profusely along with their corresponding bronchi and feed into the pulmonary capillary networks which wrap around the alveoli. The pulmonary veins then return oxygenated blood from the respiratory zones back to the left atria of the heart, atrium rather. The systemic circulation, in contrast, is a high-pressure, low-volume circuit. The bronchial arteries provide oxygenated blood to the lung tissue directly and arise from the aorta and enter the lungs at the hilum. The bronchial arteries supply all of the lung tissue itself with oxygen except for the alveolar cells because they have enough from the oxygen sitting in them. The bronchial veins anastomose or merge with the pulmonary veins, and the pulmonary veins then carry most of the venous blood back to the heart. Pleurae are thin, double-layered serosal membranes. The parietal pleura, remember parietal always means on a wall, on a body wall, are on the thoracic wall and the superior face of the diaphragm. And then the visceral pleura, visceral literally means organ. So this is the layer that's literally sitting on the external lung surface. And then between the parietal and visceral pleura, there's pleural fluid. And it fills the little slit-like pleural cavity and provides lubrication and surface tension. So lubrication is every time the lungs fill with air, we don't get this rubbing, right, painful rubbing and nerve stimulation. And then we also don't want the lungs to collapse down as we exhale. So the pleural cavity with its fluid helps with this. Now let's look at the mechanics of breathing. Pulmonary ventilation consists of 2 phases: inspiration, where gases flow into the lungs, and expiration, where gases exit the lungs. This necessitates us looking at the pressure relationships within the thoracic cavity. Atmospheric pressure outside the body, P ATM, is the pressure exerted by the air surrounding the body. Where we are at sea level, atmospheric pressure is 760 millimeters of mercury. Now, if we were to go to, say, Denver, Colorado, the mile-high city, this would be lower. Respiratory pressures are described relative to outside atmospheric pressure. Negative respiratory pressure is less than P ATM. Positive respiratory pressure is greater than atmospheric pressure, and 0 respiratory pressure is equal to atmospheric pressure. So intrapulmonary or intraalveolar pressure, known as P-PUL, is the pressure in the alveolar sacs, and this will fluctuate with breathing. but it will always eventually equalize with atmospheric pressure between inhalation and exhalation. Intrapleural pressure, or PIP, is the pressure within that pleural cavity between the layers of the serosa. And this also will fluctuate with breathing and should always be negative, meaning that it's less than atmospheric pressure and it's less than pulmonary pressure. Why? To prevent lung collapse. So intrapleural pressure, or PIP, is always negative, which serves like a little suction cup to keep the lungs always inflated. This negative intrapleural pressure is caused by opposing forces. So there are two inwardly pushing forces which are serving to promote lung collapse. One, the elastic recoil of the lungs, decreasing lung size. And two, surface tension of the alveolar fluid, which prevents the alveoli from becoming all blown out, so reduces their size. These two inward forces promoting lung collapse are opposed by one outward force, which tends to enlarge the lungs, and this is the elasticity of the chest wall, pulling the thorax outward. If intrapleural pressure equals intrapulmonary pressure, the lungs will collapse. It's like a tent where the poles have snapped. Now, pulmonary pressure, the pressure within the lungs, minus that intrapleural pressure, equals something known as transpulmonary pressure. This is the pressure that works to keep our airways always open. The greater the transpulmonary pressure, the greater the difference between the pressure in the lungs and the pressure in that intrapleural space, the larger the lungs will be, the more they'll be inflated. Atelectasis, more commonly known as lung collapse, is due to plugged bronchioles where the air can't get through, so the alveoli that are distal to those bronchioles, the alveoli that those bronchioles eventually feed with air, will collapse like a balloon with no air in it. Or a wound that admits air into the pleural cavity, right, and then that tent metaphorically collapses, and that's known as a pneumothorax. As we mentioned previously, pulmonary ventilation consists of inspiration and expiration. The mechanical processes that depend on volume changes in the thoracic cavity allow this to happen. So these include volume changes, which in turn lead to pressure changes. These pressure changes then lead to gas flow in order to equalize pressure. Boyle's law is the relationship between the pressure and the volume of a gas, or I should say it defines the relationship between the pressure and the volume of a gas. So Boyle's law states that pressure, or P, varies inversely with volume, or V, meaning that as pressure goes up, volume goes down, and vice versa. So this is defined by P1 V1 equals P2 V2, meaning if we know the pressure in one compartment and the volume of that compartment, and we know either the volume or the pressure in another compartment, we can solve for that other variable. So the respiratory cycle, again, consists of inspiration plus expiration. Inspiration equals inhalation, or breathing in, and expiration equals exhalation, or breathing out. As you can see from this diagram, we spend about a third of the respiratory cycle inhaling or inspiring, and it's faster and louder, and then 2/3 of it are spent expiring, which is softer and slower. During inspiration, this is an active process. The inspiratory muscles contract, the diaphragm, right, mainly, and thoracic volume increases. So as the diaphragm contracts, it pulls down and increases the volume of the thoracic cavity. The lungs are then stretched, and intrapulmonary volume increases. Now remember, Boyle's law states that pressure and volume are inversely related. So as volume increases, the intrapulmonary pressure decreases. It drops to about -1 millimeters of mercury. This allows air from outside the body under that 760 millimeters of mercury to easily flow passively into the lungs down its pressure gradient until the intrapulmonary pressure in the lungs equalizes atmospheric pressure. Inspiration involves the contraction of the diaphragm as well as the external intercostal muscles, the ones on the outside of and between the lungs, and as they contract, they pull the chest cavity outward, increasing intrathoracic volume. Okay, so sequence of events during inhalation or inspiration: the inspiratory muscles contract, the diaphragm moves down, the rib cage rises and expands, thoracic cavity volume increases as a result, the lungs are then stretched, intrapulmonary volume increases, which decreases intrapulmonary pressure, and gas flows down its pressure gradient from 760 millimeters of mercury outside into that minus negative millimeter space until it equalizes. Expiration involves two phases. Quiet expiration is normally a passive process where the inspiratory muscles relax, thoracic cavity volume decreases, the elastic lungs recoil, and intrapulmonary volume decreases. Intrapulmonary pressure rises to about positive 1 millimeters of mercury. Air flows out of the lungs down its pressure gradient until the pulmonary pressure equals 0. Now, it's important to note that forced expiration is an active process, and it uses both the abdominal and internal intercostal muscles to decrease the volume of the thoracic cavity even more. So exhalation involves the relaxation of the inspiratory muscles as well as the natural recoil of the elastic lungs. So as inspiratory muscles relax, the diaphragm rises, the rib cage descends and moves inward, thoracic cavity volume decreases, the elastic lungs recoil passively, and intrapulmonary volume decreases, which causes an inverse increase in intrapulmonary pressure, forcing gases up and out. Active inspiration involves the accessory muscles of inspiration, which raise the sternum, raise ribs 1 and 2, and increase thoracic cavity volume, which increases lung volume and decreases intraalveolar or intrapulmonary pressure. During active expiration, muscles of expiration actively contract, abdominal muscles contract, intercostal muscles contract. This decreases thoracic cavity volume, decreases lung volume, and oppositely increases intraalveolar or intrapulmonary pressure. When we talk about the factors that influence pulmonary ventilation, you're going to see a lot of similarities when we talk about blood flow. So inspiratory muscles consume energy to overcome three factors that hinder air passage and pulmonary ventilation: airway resistance, alveolar surface tension, and lung compliance. Airway resistance has friction as the major non-elastic source of resistance to gas flow. And just like with blood, the flow is equal to the change in pressure between two areas, in this case two areas of the respiratory tract, and over resistance, or divided by resistance. Resistance is usually insignificant because of the relative large airway diameters, especially in the first part of the conducting zone. They progressively get smaller, but they get more numerous, which increases their total cross-sectional area. And resistance disappears completely at the point where the terminal bronchioles come into play.